and then we sort of allow them to present, and at the end there is sort of debate or a discussion. But today's webinar, we've just taken a different route from our routine, and we're dedicating it to, especially for the young neurosurgeon from Myanmar and Afghanistan. Our president, Professor Yoko Kato, is there.
Hi, how are you? Thank you for. Hi, how are you? Hi.
Hi, Yoko.
Hi. Thank you for acceptance our invitation, and thank you, Russ. How are you?
Yeah, sorry I didn't get the email initially, but got it in time.
So, but you work so hard for the support of the Afghanistan and also Myanmar. Thank you very much.
It's a very difficult time in Myanmar now.
Yeah,
So,
understand. Sachin, thank you very much for organizing such a wonderful meeting. Thank you.
Thank you, ma'am. It's my pleasure.
Thank you. So, is she a Wint? Hi, how are you?
Hi. I'm good.
So what time in Myanmar now?
Currently I am in Japan, not in Myanmar.
In Japan?
Yes.
So you're working at which prefecture?
It's a Hyogo College of Medicine.
Hyogo.
Yoshimura Sensei.
Yoshimura Sensei. So you can speak Japanese.
A
little bit.
Yes, a little, only a little.
Very little, okay.
Hi.
Dr. Adam, thank you very much for acceptance, our invitation. Thank you very much.
Thank you for inviting me.
Thank you so much. So what time US now?
in California, it's 5 a.m.
5. Sorry for. Usually.
New York is fine.
Thank you.
You need to be flexible if you're going to be global.
Yeah.
No.
Japan is 9 o'clock, 9 p.m.
So the webinars usually last an hour to an hour and a half.
Generally 1 hour and a half to 2 hours. Hour and a half to 2 hours. Basically, based on the discussion, sometimes there is a heated discussion and debate, then we keep on discussing. But generally what we do is what I was telling Professor now, that our theme is one expert neurosurgeon and one young neurosurgeon, same topic, and then we allow them to present their talk, and at the end there is a discussion. So that's generally the theme. But today we've gone a little off track, and we're dedicating today's webinar especially for the young neurosurgeon and neurosurgeon from Myanmar and Afghanistan. So that's what I think we can start now. It is already 5 minutes past 9 o'clock.
So okay. Should I do the share screen?
Good evening, everyone. Myself. Let me just introduce and we can have one starting comment from Professor Yokato, and then after that, your introduction, I'll ask you to share the screen. Okay. So good evening, everyone. Good afternoon and good morning to the people from the other part of the country. So welcome to the ACNS YNS monthly webinar session. So I'm Dr. Sachin. I'm the co-chair of this committee. And today we're doing a little off track from what we do routinely every time. So today we're dedicating this webinar for training, educating, and encouraging neurosurgeons from Myanmar and Afghanistan. So we have a team of wonderful speakers today, Professor Landru and Professor Tariq Khan, Professor Adam Amar, and a young neurosurgeon from Myanmar, Dr. Shui So before starting the webinar, may I request our President, Professor Yoko Kato, to say a few words.
Thank you so much, Sachin, the making such a wonderful meeting. So every day I saw the TV, and today also I saw the TV about some tragedy of the very big accident of the Kabul accident, and also every day also we have such a very sad news from the member, and still they have some struggle to improve their situation, I think. Today, so I think the wonderful speakers, maybe we can have some discussion of how we can support. It's quite difficult to the support by books and DVD, but maybe we can give them some kind of the education in any way. So we are very much looking forward to your lectures. Thank you very much for tonight.
Thank you. So with that, we'll kickstart our webinar. Allow me to introduce our first speaker. Our first speaker is Professor Russell Andrew. He's he's advisor to the nanotechnology and smart system that is under control of NASA. He's a member of Aerospace Medical Association. He's also a past chair of American Association of Neurological Surgeons, International Outreach Committee. He's an executive member of our ACNS organization. He is a program committee member of computer-assisted radiology and surgery. He's also board director of Epilepsy Foundation of Northern California, a member of ENS, and a member of EPMA. Apart from that, he's an advisory board member for International Association on Neurosurgeons. He is the president of International Conference on Neuroprotective Agents. He's a member of the Society of British Neurological Surgeons, and he is a guest lecturer on robotics and design of future education at Stanford University. He's also a newsletter editor of WFNS, and he is a member of WFNS NEUROTRAUMA, Neurorehabilitation and Mass Casualty Committee. And he's a section and feature editor of very well-known Journal of World Neurosurgery. So with that introduction, I will hand over the screen to Professor Russell Andrew, and he's going to talk and discuss with us about how to improve the current situation in the Myanmar and how to improve the and get back our medical colleagues to the work. He wants his discussion to be a little interactive. So if you have any doubt, any question, please feel free, and let's have this discussion more interactive towards how to help our colleagues in Myanmar. Thank you very much. Over to you, Professor Russell Andrews. You can share the screen now.
Okay. Can we go? Okay, does everybody see this okay?
Yes.
It's coming through?
Yes.
Well, I just want to emphasize this situation in Myanmar is really unlike anywhere else in the world. And our healthcare colleagues there are being held hostage and literally being, in some cases, executed by the military junta. So this is going to be just documenting this and offering some suggestions on how we can hopefully improve the situation. It's been quite frustrating so far. It's 3 months now. Here's some of you may have seen this. This Burmese woman is doing her morning exercise, and she doesn't realize with this video that in the background the civilian government was elected several months previously, was to meet on February 1st, and the military junta basically arrested all the civilian government and detained them. The doctors have been really severely affected by this, as you may have read. This is quite a recent article. I'll just run through a few of these documenting what's happening to the healthcare system in Myanmar in the last 3 months. And you can see here the protests that the doctors really and healthcare workers are at the forefront of. And various human rights groups have been pushing for not only an arms embargo, but an economic embargo of the military junta to cut off their funding. This shows you how cruel this military junta is. They will, one, murder protesters and then charge the families to pick up the bodies that they've killed. This is, I think, unheard of in in any world experience. And so we have to realize we're not dealing with human beings here. If you're a pediatric neurosurgeon, it's pretty hard to operate when your children are being killed. There's over 40. This was over a month ago, and so the number is probably closer to 100 by now. And this is just an example. In March, one day, more than 100 people are killed in one town in Myanmar just for protesting. And here's the doctors. You can see in Yangon General Hospital with a three-fingered salute, noting that when people are shot, many times they're unable to provide any assistance just because the military will not let them attend to those who've been shot. And again, if you're interested in gunshot wounds to the head, there's going to be no shortage in Myanmar. These are really executions. This is not control of violent people. And you can see here they're using social media to intimidate the population of the country. This is really a fratricide. It's really one step beyond a genocide. There's a small cadre of military people murdering their citizens just to maintain control of the country. Sorry if this is pretty blunt, but I think we really have to be frank about this. If we're going to pretend to be physicians, you're going to end up being dead, and if we allow the world to be taken over by people like this. And interestingly, women have been very active in resisting. This is using some ethnic opinions or views to provide a psychological advantage in your resistance. And has been noted and very appropriate for this group is the young people are the ones who are really at the forefront this time in protesting the coup that is now 3 months old. So I think many people listening probably are not too familiar with how this came about. So I was going to spend a few minutes on some background here. There's 3 maps of Myanmar. On the left, you see a kind of standard map with the main cities. And it's saying, Myanmar is between Thailand, Bangladesh, and India, and China. And then in the middle, you see the divisions, the different states, and then the ethno-linguistic divisions on the right. A dramatic increase in population over the last 70 years or so to over 50 million now. In the top right, you see some of the major cities. Yangon, the capital, is over 5 million population, and so on. And the bottom, you see on the left that the majority of the people, 9/10, are Buddhist. And this kind of fits along with the ethnic groups to some extent, the Bamar being the main ethnic group. But there are these very involved ethnic minorities. That's been a problem, but the military junta tends to foment resistance against the ethnic groups, really taking the Bamar majority and using these ethnic groups as kind of pawns to solidify their control. Just a brief timeline here of what's happened over the last 70 years or so. You're all familiar with Aung San Suu Kyi. She was born in 1945. And when she was 2 years old, her father, who really negotiated independence of Burma at that time from Britain, was assassinated. And a few months later, Burma did in fact become independent. the civilian government or quasi-civilian government at that time was not very effective, and there was a military coup d'etat in 1962, really the first one, and a number of students at Rangoon University were killed at that time due to protests over this military takeover. This boiled over again in 1988, and when reportedly thousands were killed. It's I think hard to know for sure how many. And the military changed the names of the country to Myanmar and Rangoon to Yangon, et cetera, kind of solidified their control over the country. There were elections shortly thereafter where Aung San Suu Kyi's party won, but she was placed under house arrest. A typical pattern that's really repeated itself over decades now. The monks rebelled about in 2007, and several of them were killed. Really a good example of how inhumane this military junta is. In Cyclone Nargis, 150,000 deaths roughly are estimated. The government actually refused humanitarian aid. It was offered by the UN, WHO, and other organizations. So we're not sure how many of those deaths could have been saved had there been some help from outside. In 2008, there was a constitutional referendum or elections a couple years later of questionable validity. But in 2011, which Professor Kato organized one of the first meetings there was this opening, this quote unquote disciplined democracy, although the military really maintained control in the background by having a portion of the seats in parliament. There were elections in 2015 where the civilian government, to the surprise of the military, won about 85% of the vote. The following year, Aung San Suu Kyi was named a state councilor. She was barred. They specifically created a law saying that you couldn't become prime minister if your husband or your family, her sons were born in Britain. And so that barred her from becoming prime minister, but she became state councilor, which is somewhat similar role. And that same year, the Rohingya genocide, which you're familiar with, began in the northwest of the country. There were elections again in 2020, and again, the civilian government won about 85% of the vote. Military, however, complained that this was a fraudulent election. It brings memories of what's going on in the US right now. So I have some, very close to home reasons to be very concerned about what's happened in Myanmar. Could happen anywhere. And then on February 1st, the military basically removed the civilian government just as they were set to convene. And this is a picture I showed a little earlier of how, what exactly happened kind of out of the blue, just as the government was to take control. Well, I mentioned the problem with the Rohingya. Colleague in Bangladesh, Sumitra Sarkar, arranged a couple, it was about 3 years ago now, spent a visit to the Rohingya camps near Cox's Bazar in southeast Bangladesh, and where there's about 700,000 refugees in very primitive conditions. And you can see in the upper right there, that's the border, that little ditch there with some water in is the border between Bangladesh and Myanmar. These camps really are not very secure as far as fencing, for example, but people have no documentation, so they really can't go anywhere anyway. These are really people without a state. And you can't really see it up there, but there's a watchtower up on the Myanmar side, and there's probably a sniper who could take out anybody who might want to kind of escape, quote, back into Myanmar, although the Rohingya certainly are not interested in doing that, given what's happened. This is the healthcare facilities on the Cox's Bazar Rohingya camp. You can see the laboratory has fairly limited testing they can do. And in the bottom, the emergency room basically consists of an oxygen tank. So you can imagine what the delivery room looks like. And that's really it. The only other, let me go back, the only other medical resources at the time I was there, the Scandinavian Red Cross was providing surgical services outside the actual camp but nearby. That was to end at the end of 2018. There really is no surgical services other than what's available in Cox's Bazar, which is fairly limited and not really available to the Rohingya. There is a church-based hospital facility several hours away. So there's basically no surgical facility for this 700,000 people. Well, if we turn now to what's happened since 2011, actually that conference that Professor Cotto sponsored in 2011 was just shortly after Hillary Clinton made a visit, and apparently she returned with Barack Obama the following year. You can see on the bottom there the entertainment that the Burmese provide in these courses is quite interesting. They've finished their set. This is a group of dancers with Lady Gaga's Born This Way. And in the upper right, there's outside of Yangon, there's a wonderful memorial for the World War II resistance. This is with a few of the neurosurgical colleagues there. There's tombstones from everybody, not just the Burmese, but the people from Southeast Asia, particularly the Indians and the British that fought for the Burmese on the Burmese side. Well, if we look at what's happened in neurosurgery over this past, quote, decade of disciplined democracy, there's really been quite a bit of progress. The government has in many fold increased its economic support of fields like neurosurgery. The first boot camp was held in 2017. The actual operating rooms have become reasonably well equipped, although as you'll see throughout the developing world, the wards are pretty basic and rely a lot upon the family members for support. And you can see Yangon General Hospital there in the aerial view. I want to acknowledge the work that Jack Rock from Henry Ford in Detroit, in the USA, has done establishing a twinning system with Yangon General Hospital over the last 6 or 8 years. And I won't read through all that, but there's basic exchanges that go on between Henry Ford Hospital in the USA and the hospital in the Yangon General Hospital. He sponsored a boot camp, the first one again in 2017, the second one in 2019. And for his efforts, he was awarded the humanitarian award of the ACNS in 2018. We should also acknowledge Philippe Schuch in University of Bern in Switzerland. He's done a very similar twinning system between Switzerland and both Yangon and Mandalay General Hospitals. So they have really made a remarkable contribution to developing neurosurgery in Myanmar. There's an article that's just coming out in World Neurosurgery about the conditions in Myanmar with the coup, a neurosurgical community under attack, which you might want to take a look at. Philippe was the first author on that. Well, what can we do to kind of combat this deadly coup that has occurred? Well, within 3 weeks, a group of physicians in Myanmar had a publication in the Lancet, as you see here. Unfortunately, there hasn't been that much support for it. The United Nations Office of the High Commissioner on Human Rights has said the right things, but not that much has happened. You can see here some quotes from Michelle Bachelet from Chile, is now the UN High Commissioner on Human Rights, and has been very supportive verbally, but there's not much they can do physically to actually undo what happened on February 1st. Probably the most supportive person has been the UN Special Rapporteur on Human Rights for Myanmar, Thomas Andrews. And I just mentioned he's been very supportive of the resistance, but again, it really is the Security Council that needs to act. And as long as China and Russia will not support interventions, it's going to be a stalemate. One of the most encouraging episodes has been this webinar a couple of weeks ago. It was organized by Lord Nigel Crisp, who is chair of the All-Party Parliamentary Group on Global Health in the British House of Lords. Thomas Andrews actually spoke at this and spoke very movingly about the need for economic embargo of the military in Myanmar. And fortunately, most companies have taken this on, divested themselves of support of the military junta, but not all. In the US, Keith Martin, who is executive director of the Consortium of Universities for Global Health, Michelle Berry, who runs the Center for Innovation in Global Health at Stanford, gave it's a blog. If you go to medium.com, you can see it really documenting what's been going on in Myanmar and hoping to raise support for that. I think we'll hear probably from Adam Amar about the work at Harvard, the program in global surgery and social change. They had a webinar a little over a month ago to support the healthcare workers in Myanmar. This is just an email from Walt Johnson, who many of you know was the WHO lead for emergency and essential surgical services until a couple of years ago. And so this was circulated amongst a number of people there. And Walt's been very supportive as well. But again, words don't really matter when you have a regime such as the military junta in Myanmar. Other groups that should be doing a lot more is the ASEAN, Association of Southeast Asian Nations, of which Myanmar is one of a number of members. And they met also a couple of weeks ago and really, they said the right things, but are really doing nothing to correct this situation. Very interestingly, the former UN Secretary General Ban Ki-moon came out a few weeks ago and said quite literally that the current Secretary General Antonio Guterres should go directly to Myanmar and intervene. And unfortunately, this has not happened. I'm not sure why. If the Security Council won't act, that the UN doesn't take it upon themselves to be a little more assertive. The UN really, quite frankly, runs the risk of going the way of the League of Nations, which some of you will remember after World War I became so powerless that it just dissolved. And the UN, if it doesn't take action in situations like Myanmar, may go the same way. Quite close to home, I'm very sad to report that Chevron, which is an oil company, was second largest in the US, based here in California, was actually lobbying the US State Department to not be held to the sanctions against the Myanmar junta. They run some gas operations together with some European oil companies with this Myanmar oil and gas enterprise. So I've written letters to the editor. Again, unfortunately, this probably doesn't do much good, but we're going to keep working with the State Department to bring Chevron and other companies to cut off their funding that indirectly gets to the military junta. Again, most supportive probably of this whole action is the young people in Myanmar. I'd suggest you look at progressivevoicemyanmar.org. As they said recently, the junta is, you've messed with the wrong generation, that the younger people are getting much more aggressive at resisting. And I think this time they've decided, both the young and the old in Myanmar, from my talking early on with the colleagues, neurosurgical colleagues, this is it. They're fed up with the military, and they will. The question is, when do we intervene and end the killing? Is it going to be after 1,000 deaths, 100,000 deaths, or again, 85% of the population vote? They're going to kill 45 million people before the junta is deposed. I want to end with a couple of promising notes. Interestingly, some of you may know Mimi Aung, who's Burmese by birth, was the lead engineer in the recent helicopter that flew on Mars. So there's some very talented people who have come out of Myanmar, and we need to support them. And I will finish with this slide. This was taken in 2015 in a monastery near Mandalay, and this is a young boy with a cell phone blaring music in his pocket, trying to look in and see the monks. So I would encourage all of us, young and old alike, to stay curious and stay courageous, and we really need to support our colleagues in Myanmar. They're dying for our independence and freedom. With that, thank you.
Thank you very much, Professor Russell Andrew, for that brief review of what is the situation in Myanmar and how horrifying it is. We all stand in support of Myanmar. Actually, ACNS has formed a ACNS Myanmar support group. Under this support group, I am in contact with at least 30 to 40 young neurosurgeons from Myanmar. I had requested all of them to join, but because of the poor internet facility, not all of them are able to come, but few of them are there definitely. So if anybody has any, we should do the discussion on this now or at the end. What do you think?
Well, I'd just like to comment that we have to be very careful about communicating with our colleagues in Myanmar, because certainly the government is monitoring any internet connections, and certainly I purposely avoided any pictures. I guess there was that one at the War Memorial of healthcare workers in Myanmar, because this junta is targeting those people. And we may feel like we're being supportive by trying to get in touch with them, but we're actually putting them at greater risk. This is war. This is, I mean, it's hard to talk about neurosurgery when they're in this sort of situation, because if we don't act as concerned human beings and kind of forget our neurosurgery aspect, they're just going to wipe out the healthcare workers in Myanmar. Because they're part of the major resistance to this junta, and the junta has no conscience. They don't even want to. This isn't like the Taliban in Afghanistan. This is a group that will do anything to maintain control. So I think if we're really very naive and really not fair to our colleagues in Myanmar, if we think just by communicating with them and saying, "Oh, we support you," we're actually putting them at greater risk. I think. If the picture goes on the internet, that may be a target for the junta. So sorry if I'm pretty blunt, but I think we got to be realistic. It's well past the point of being kind of nice guys as doctors like to be.
Sure, definitely, that is a very valid point. I think the content of discussion with them should be very appropriate. So if anybody wants to make any comment, Dr. Sui is there from Myanmar, or Dr. Hietwin Kiao is there from Myanmar, Dr. Su is there from Myanmar. Anybody from Myanmar, anything you want to say? Of course, again, be careful with what you say, as Professor Russell Andrew said, but something which is non-political and something which is more of a humanitarian words, if you want to say something. Dr. Su, you want to say something?
Yes, thank you so much, Dr. Alice. Let me express my great appreciation to you all for being together with the people of Myanmar through this epic times. And thank you for your support.
So are you in neurosurgery training, Dr. Su?
Yes.
So in which year are you training in?
Sixth year.
Sixth year
resident.
You are in your final year. So what is the status? What is the status of your training now? Is it going on? You're still going to the hospital, or it's totally shut down?
It is a little bit complicated, and this military coup delayed all our hope, and our residential training has stopped.
Okay, I understand.
Yeah.
Okay. All of us, we stand in support for you. And as long as your neurosurgery training is concerned, we'll try to do whatever best we can, whatever through the webinar, or in terms of, maybe nowadays we're planning to do a hybrid cadaver webinar where we can do a hands-on cadaver workshop in the country, and the same can be put on live, and the other part of the country or different country neurosurgeon, young neurosurgeon can also see. Anybody else want to say anything?
I would like to say something. I just would like to express my thanks, sincere thanks to Professor Russell Andrew and also Professor Yuko Kato and all of you who stand in the same page with us, who care for what is happening in our country. It's really touching, and it's really encouraging, and it gave us a bonus to go on until the gentle ends. And this is our decision that we will fight till the end. What is happening in Myanmar is all included in Professor Russell's slides. I hope you all know it, and even some of my colleagues from Mandalay. I'm a neurosurgeon from Mandalay regions, and some of our colleagues, they are running from the military. So it's very hard, and even like there are times that even during the people are protesting, there are people dying, even they are shot to their head, and and we can't do anything, and even like all the government hospitals are closed, and we doctors trying to save people's life in some very remote area, the small hospital and some of the hospitals, but even the militaries try to stop us from saving people's life. That's true terrible. So that's what happened. So, and I just want to say my sincere thanks to all of you for your support, and we'll look forward to to see a brighter future together in our country. Thank you all.
Thank you, Dr. Win. Dr. Win, may I ask, what is the status of COVID pandemic at the moment in your country? How is it going?
The COVID condition, I think, I don't know why, it's really, it's for me, it's by the grace of God, that the COVID seems like under control, no COVID, patients have been detected so far, but I don't know nowadays, because of like in India and our borders country, there are COVID happening, but miraculously, in our country, the COVID have been, like even though there are a lot of thousands and thousands of protesters, we don't see any, we don't hear any news about the COVID patients, up to now.
Okay. Thank you very much. We all pray that you take care of yourself, your family members, and stay together, strong. And we pray that soon you come out of all this thing. Anybody has any other comment or any question or any suggestion?
I thank you very much for Russell and a very nice talk. So as the level of the government, the Japanese government, we assisted the military of the Myanmar when they formed the military system. So I think we are very weak, just one of the citizens, but the Japanese government can already the touch with the military, the groups and the head of the military. Maybe I think some improvements already some Japanese society and the government work for the military peoples. I think it's make some help, I think, in the future. And for the young doctors, maybe as a ACNS, the Liu and the young YNS committee, all members are thinking about your improvement of the knowledge and the skills, even this situation. So just let us know what you want. Maybe we can give some webinar or live hands-on or whatever you want. We do our best for all of you, I think. Stay safe. Thank you.
Thank you, Professor. But just have a small question to Professor Russell Andrew, that since you've been following it since the beginning, and I think you are the expert of like this situation. What do you think, in your opinion, how long this is going to go and how is this going to end? What do you think?
Well, I think until the UN Security Council or the ASEAN really intervenes, it's just going to continue to get worse. It's very hard to economically strangle the military junta. I mean, that would take probably years. We've seen sanctions in various, a few other countries that, people work around that. So, and unfortunately, well, quite frankly, Russia and China are probably supporting the military junta. They clearly don't want the UN to intervene. We're basically at a juncture in the world of whether we want authoritarian regimes or we want independence and, democratic regimes. And so Myanmar is kind of a test case. So this is very similar to what happened in the US last fall with our elections. We very nearly had an authoritarian individual take over the country. And, you can't look the other way. So this will go on until people stop looking the other way. And I think if we kid ourselves and think this is going to solve itself, it doesn't. We each have to really latch on to our colleagues in Myanmar and say, we're going to work with you people. You're our colleagues worldwide, and we can't look the other way and say, oh, it'll solve itself and I'm going to just deal with neurosurgery. I think we're at a crisis point in the world now that it's just going to slide further and further into autocracies around the world if we don't, do what all the people in Myanmar, basically, especially the young people, are doing. They're putting their lives on the line, and we're going to need to do the same thing. So it's going to last as long as we just talk about it and don't do anything. And so the question is, getting in touch with our state departments, as Professor Kato said, the governments. They're slowly stepping up, but it's a question of how many people die before action is taken. And so I encourage everybody to not say, well, let's see what it's like in 2 months. It's going to be 2 months worse and thousands more die. So just think about who you can contact in your own country, that in the government, and lobby the United Nations. They're already protesting. The Myanmar people in the U.S. Have been staging some demonstrations, not getting publicized very much at the UN and in New York. We just have to keep this up and make it so overwhelming that the UN has to act. I mean, that's what they're there for. They're supposed to maintain civility around the world, and they're certainly not doing that.
Thank you very much, Professor, for your expert opinion about and giving us a brief review of what is the situation in Myanmar and showing us some direction how to go ahead with this. Anybody has any comments?
I would like to just add some updates during this week, and during this week, what happened in our country is you heard about the National Unity Government is the elected people. They formed actually in 2020, elected parliament members, they formed the National Unity Government, and just a week ago, they formed the People Defense Force. It's a first step for the federal army. So they are going to fight against this military junta. So that's what happened, and right now there are some wars happening in some area of country, and they are also and I think that People Defense Force, they have some arms supply from where we don't know, but they have formed this also. That's what is happening during these days, and the military seems to be a step going backwards and not really pushing too much upon this the healthcare workers. But unlike last month, at the end of last month, like April, last week, the pressure have been going on and on upon this these healthcare workers, including us, for us, they force us to work again in the government, the hospital, Thank you.
Thank you for giving those recent updates. Thank you very much. If there are no questions, then we'll move forward. My co-moderator is Dr. Liu. He will now introduce the second speaker, Professor Mohammad Tariq Khan.
Thank you, Sachin. It gives me a great honor to read out the brief CV of Professor Mohammad Tariq Khan. He is currently a chairman of Alliance Healthcare Limited. He is also a Dean of Neurosurgery, College of Physician and Surgeon of Pakistan, and also Dean Northwest School of Medicine, Peshawar, Pakistan. He is also a professor and head of Department of Neurosurgery in the same center. He's currently the chairman of the World Federation of Neurosurgery NEUROTRAUMA Committee, and also a member in the NEUROTRAUMA Committee of ACNS. He's also a convener NEUROTRAUMA Committee of Pakistan. He also holds a position of a past president of Pakistan Society of Neurosurgery and a director board member of a few organizations, including DOS Foundation, Regional Institute for Policy Research and Training, Abdul Hashim Khan Trust, Pakistan Red Crescent Society, Aziz Jansos Village School, Haya Tabat Peshawar, and he is also a faculty for ACNS and director Pakistan Human Development Fund, and also a member of the National Academic Board of Pakistan Medical Commission. Today he will we speak to us on neurotrauma care in the low and middle income country. With that introduction, may I call upon Professor Mohammad Tariq for his presentation. Thank you.
Thank you, Dr. And thank you, Sachin and Professor Yoko, for inviting me to this seminar, this meeting. It's very sad and heartbreaking to see what is happening in Myanmar and, of course, in Afghanistan. In Afghanistan, has been going on since the early 70s. But we must remember that the work of the doctors, the work of the neurosurgeon must go on no matter what is happening around that. So I thought it was an appropriate topic to discuss about the neurotrauma management guidelines for lower and middle income countries. Here, no, sorry, again, I've got a problem. I felt this was a very important topic to be able to discuss. Let me stop sharing and do it again. Yeah, so this is where I work in Northwest General Hospital Research Center in Peshawar. So this is a workforce map of global neurosurgical in the world. This was done by the WFNS. A lot of work was.
Sorry, Professor, we're not able to see your screen.
Oh?
So we're not able to see your screen.
Hold on then. Sorry.
So you just have to switch your presentation, the one that is open. You just have to switch the presentation.
Yeah. Can you see it now?
Yes, it's
Yes,
visible.
it is visible now.
Yeah, okay. So this is a global workforce map, which was put up by the WFNS. A lot of work was done by Key Park and his colleagues on this, and it shows the areas of the lower and middle income countries with very few neurosurgeons in that area. And And as we know that 74% of surgeries for TBI are needed in lower and middle income countries, and yet the number of neurosurgeons are very few in these countries. And we also know that 89% of surgeries for traumatic spine injuries also occur in lower and middle income countries. Looking at all this, we need to develop a holistic approach towards the management of neurotrauma, and this has to be looked at from the point of view of prevention, pre-hospital care, emergency room care, ICU care, theater ward care, and then most important, rehabilitation. So I'll just take you to this neurotrauma survey, which we did of the Asian Association Society of Neurosurgeons, and 3 countries, our country, India, and then in Indonesia, we did some studies, a basic audit of patients admitted in neurosurgical wards. And we looked at the helmet and seatbelt use, and we found that majority of the people were not wearing any helmets or seatbelts. And then we looked at this, and we have this knack of putting as many people on motorbikes, and we think that one helmet can protect all of us. So no helmets, and then so many people on the motorbikes. So we felt that prevention was the most important step which we had to take in this region, in lower and middle income countries around the world, so that we could reduce the burden of brain and spine trauma. And we started this hereditary prevention program, and we started this now in many countries. And this is done by poster exhibitions and by seminars for the public to do that. And recently, the World Federation of Neurosurgical Societies Neurotrauma Committee joined hands with the Think First International Foundation, and so that to try and work together for prevention. And we had our first seminar during the ICRAN 2019 in Peshawar, and it was a great success. Nearly 1,000 people, non-doctors, attended this seminar. It was a great help, really. Then this survey looked at who provided emergency treatment at the scene of injury, and in majority, as we can see, that it was a member of the public which were doing that at the scene of injury. And then we looked at, did a nurse and doctor accompany the patient? And only in a couple of centers in Indonesia, we found that there was a doctor and nurse accompanying the patient. Majority, there was nobody in the ambulance. There was no oxygen. There was no suction available. So these patients were just transferred, dumped into a vehicle and transferred to the nearest hospital. And as we know, it's the most important that the 50% of patients who die from traumatic brain injuries do so within 2 hours of injury, and 40% of pre-hospital deaths are potentially preventable. And this study shows that there were 59% of trauma deaths occurring in the field in high-income settings. We're comparing it to 72% in middle-income countries and 81% in low-income environments. And we could see that in Kenya, 52% of patients arrived at the hospital within 30 minutes after a road traffic accident, and only 72% arrived within 1 hour. So we know that it is very important that the pre-hospital care should be done. And then we looked at that the duration of surgery was very high in our lower income countries. From our experience and from all the documentation, we know that treatment is geared towards prevention of secondary injuries and rehabilitation. And secondary injuries like hypoxia, hypotension, edema, raised intracranial pressure lead to increased mortality. So longer the delay, greater the mortality. So it was great emphasis was laid on and is laid on pre-hospital care, pre-hospital training in that. And you people may have read this recommendations of the Colombian Consensus Committee for the Management of Traumatic Brain Injury in Pre-Hospital Emergency Department, Surgery and ICU, called Beyond One Option for Treatment of Traumatic Brain Injury, a stratified protocol bootstrap. So it's not it's a resource driven protocol, and we wrote a commentary on that, saying paradigm shift from standard driven protocols to resource driven guidelines for neurotrauma management. So it's As you know, in the higher income countries, it is a standard driven protocol. There are golden rules and you have to follow those. But in lower and middle income countries, something which is not possible. So the WFNS, with the help of the Colombian Consensus Committee, looked at protocols as resource driven. So you could see whether you could transfer patients who were less serious in normal ambulances and more serious in high type of ambulances. So the guidelines, obviously, they're setting the minimal standards from the care of the accident site, and then we agree on a minimal standard of care, and then a system of care which grows as trained personnel and resources become available. So we can't say that we cannot develop guidelines because we don't have the resources. No, whatever resource we have, we can develop those guidelines slowly from that, and we need to assess the local data, look at the transport difficulties, and look at the resources, and we can develop our protocols. So every country of lower and middle income can develop their own guidelines looking at our resources. So we don't have to depend on the high guidelines. We know that the in-hospital management is guided by the GCS monitoring, by CT scan, by ICP monitoring, by pupillar response. And the goal is supportive treatment and prevention of secondary damage. Of course, many countries may not have ICP monitoring. There might be some countries which might have difficulty in CT scan, but we have the pupillary response and the GCS monitoring, which is available to everybody. The BTF guidelines, evidence-based, show that the general maneuvers with head elevation, neutral position, normothermia, sedation, and volume resuscitation. And then the first line of therapy, CSF drainage if you have a ventricular catheter, or hypocapnia, and mannitol administration or saline. And then the second tier, high dose barbiturates, intense hypoventilation, increase in mean arterial pressure, mild to moderate hypothermia, and decompressive craniectomy. So there's certain of these things which are not available in lower and middle income countries, but certainly head elevation, sedation, volume resuscitation is available, mannitol, 3% saline is available, and decompressive craniectomy is available to everybody. And again, coming to the BTF recommendations, it says that there's 2A level evidence that bifrontal decompressive craniectomy has been shown to reduce intracranial pressure and stay in ICU, but not the extended Glasgow outcome score at 6 months. And also that whenever you do a decompressive craniectomy, it should be a large fronto-temporoparietal decompressive craniectomy, at least 12 by 15 centimeter for reduced mortality and improved neurological outcome. And regarding ICP monitoring, there's 2B level evidence that it reduces hospital stay and 2-week post-injury mortality, and that ICP should be monitored in all salvageable patients with GCS 3 to 8 after resuscitation who have CT changes. And it's indicated in severe TBI with normal CT, but having 2 or more features on admission, age greater than 40, unilateral or bilateral motor posturing, or systolic blood pressure less than 90. So ICP monitoring can be done if you have a monitor available and if you can do an intraventricular catheterization. In the lower and middle income countries, we know that majority are managed without ICP monitoring, and that's even in the case in high income countries. There's no recent literature to guide management in non-monitored patients, and large part of literature comes from well-equipped, larger centers in higher income countries, and there are no resource-based guidelines in LMICs to guide TBI management. You know, Randy Chestnut's trial, the Best Step trial, 2012, provided the only tested non-ICP monitored treatment protocol. And this trial found no evidence of outcome differences for monitored and non-monitored patients. And this trial compared ICP monitored patients with imaging and clinical examination, that is ICE protocol, something which can be easily done in the lower and middle income countries. And then there was another paper written by them, was consensus-based management protocol, the CREVICE protocol, imaging, CT scan, and examination for the treatment of severe traumatic brain injury when intracranial pressure monitoring is not employed. So this is not a substitute, but a supplement for empirical evidence in efforts to provide for the vacuum left by absence of evidence-based guidelines and developed using the Delphi technique with 43 intensivists and neurosurgeons. So there was a great study, a great protocol was developed, and I'll tell you about how it is done and how we are doing it. So in our center, we have 3 protocols which we do. We either do a decompressive cranectomy on admission, depending on patient condition, and if we can put in an intraventricular catheter, we would do ICP monitoring and then manage according to the ICP, or if not, then we use the CREVICE protocol. So the indications for decompressive cranectomy are the CT findings of diffuse brain edema with or without brain contusions, subdural hematoma, the effacement of basal cisterns and ventricles, if there's a midline shift, a GCS of 9 to 12 or a drop of 2 degrees from the previous. And we believe that the age should be less than 70 because there's a very high mortality over 70. And if you're doing ICP monitoring, then refractory ICP. Then using the CREVICE protocol, it depends on the Marshall score on the CT scan, doing interval CT scans, looking at the Glasgow coma score and neuro worsening and pupillary response. These are some things which can be done fairly easily in lower and middle income countries. And then there's a 4-tiered management response. You all know the Marshall grading, which depends on the cisterns, the midline shift, and the mass lesion. And the intracranial hypertension is suspected and treatment recommended in the presence of 1 major or 2 minor criteria. And the major criteria are compressed cisterns, looking at the CT classification, midline shift, non-evacuated mass lesion. And the minor criteria are the GCS motor score of 4 or less, pupillary asymmetry, abnormal pupillary activity, and then the CT classification. And neuro worsening is look at decrease in the motor GCS of 1 or more points, new loss of pupillary reactivity, interval development of pupil asymmetry, mydriasis, new focal motor deficit, and herniation syndrome. And the imaging schedule for the CREVICE is initially doing a CT scan, then repeating at or after 12 hours, if initially is done at less than 4 hours, then at 24 hours, then at 48 hours, and then as and when it is required. So the management is, tier 1 is scheduled hypertonic saline, 4-hourly scheduled mannitol, 4-hourly maintaining normothermia. Tier 2, if there is neuro worsening, then is hyperventilation, hypertonic saline, and continuous infusion, and increase in sedation. And then tier 3, which is easy for lower and middle income countries, is to go for decompressive cranectomy, or if possible, then high dose IV barbiturates and hypothermia. And then the untested protocols of hyperventilation, hypothermia, nimodipine, and magnesium. So decompressive cranectomy or high dose barbiturate stands out in some places where we can, in the lower and middle income countries. And when do you escalate the tiered therapy? It should be when there's neuro worsening, when there's no improvement or worsening on follow-up CT imaging, or there is no acceptable response to initial therapy. And this is how you do the tiering. And then you look at the support matrix, which depend on the Marshall score, the pupillary response, and the motor response. And you see when you can start weaning off the ventilator, and the green is when you can try and reduce the ventilation. You can see that in the first 48 hours, there's very little chance of removing the ventilation. And then gradually, as time goes by and the patient conditions start improving, you can try and look at weaning off from the ventilator. So I would recommend that we do a study at some stage on this CREVICE protocol and look at ICP monitoring. There's been a lot of work done on decompressive cranectomy, and then there was an international consensus meeting back in 2017 in Cambridge, and this was the consensus statement for meeting on the role of decompressive cranectomy in the management of traumatic brain injuries. I think you all need to look at that. It is a very important document for everybody to see. The most important, when the patients get out of danger, when they don't require ventilation, when they're off sedation, then what happens to them? And we looked at the majority of the patients are being sent home to their families. What can be done? It is one of the most important parts, often neglected in developing countries due to poor resources. We've looked at the role of family members, and we are working with Cambridge University, with them to see whether, NIHR, to see whether we can develop a role for the family members, to train the family members in rehabilitation and let them do the rehabilitation at home. Back in 2019, we developed the comprehensive policy recommendations for head and spine injury care in lower and middle income countries with the help of Harvard School of Medicine, a PGHC progress in global surgery. And this was a need for unifying vision for global neurosurgery, that 80% of the world has access to essential neurosurgical care by 2030. 80% of the world is within 4 hours of a neurosurgical center by 2030, and that the 90% of LMICs have a national neurotrauma plan in place by 2021. Unfortunately, because of the pandemic, many of these deadlines may be missed. These were the deadlines, and we were hoping that we could culminate this in Bogota in our meeting, hopefully, which will be now in March next year. In Pakistan, we were able to develop the National Vision for Surgical Care 2025 in line with the Universal Health Coverage 2030. And we were able to piggyback some of the recommendations of the comprehensive recommendations for brain and spine injury, LMICs, onto this national vision, especially on head trauma and on hydrocephalus. Then a little about global neurosurgery. In addition to doing neurosurgery better, how to better deliver neurosurgical care to all who need it. And it's very important in this day and age, looking in Myanmar and looking at Afghanistan, looking at many other countries of the world. And this launching of the Global Neurosurgery Committee of the WFNS was done in the ICRAN 2019 in Peshawar. And the idea was to achieve universal access to neurosurgical care, to align and coordinate all global neurosurgery activity within WFNS to reach the goal, to stimulate and facilitate relevant research, to inform policy, to engage with surgical stakeholders for building integrated surgical systems, and to co-educate for investing in surgical care for all within universal health coverage. And we know there's been a lot of discussion about neurosurgery by non-neurosurgeons because of long distances. And an example is in Australia, where they're still using general surgeons to help do some basic neurosurgery. And now with the teleradiology, with Skype, virtual surgical assistant, having guidelines, good communications, we can develop local expertise, although it is a controversial point, but we can look at non-neurosurgeons to help overcome this shortfall of neurosurgeons. Thank you very much for the time.
Thank you very much, Professor Tariq Khan. That was a very nice overview of status of neurotrauma in low and middle income countries. And you already mentioned the global neurosurgery. So since both the topics are similar, we'll quickly take Professor Adam Amar's topic, and then we'll have a discussion at the end. Is that okay, Professor?
Yeah, that's good with me. That's fine. Adam can do that.
Sure. So may I request Dr. Sneha to kindly introduce Professor Adam Amar. Dr. Sneha, are you there? Okay, then allow me.
Sachin, can you hear me? Yeah.
Yeah, sure. Go ahead.
Yeah, it's a pleasure to introduce Dr. Adam Amar. He's had his education from the University of Illinois at Chicago College of Medicine. Subsequently, from the Johns Hopkins University, he's having a BA in neurosciences. His neurosurgical training also includes a global neurosurgery research fellowship at Harvard and also from the Albert Einstein College of Medicine, Montfort Medical Center. So he's having several honors and awards to his credit, which include several research awards, scholarships, and honorary medical society awards. His global work include the Global Neurosurgery Initiative program from the Harvard Medical School. He is a member of the WFNS Global Neurosurgery Committee. He's a co-founder and editor, assistant editor, Journal of Global Neurosurgery till date. The Secretariat co-chair, Global Neurosurgery Committee, WFNS. He's having several peer-reviewed publications. It's a pleasure to introduce Dr. Adam Emmer. Welcome on board to this committee, and can we please have your presentation? Thank you.
Thank you for that wonderful introduction. And thank you for having me today. Can you see my screen? So in line with what Dr. Khan was just speaking about, I wanted to speak today about global neurosurgery and efforts that we have to expand it around the world. And I just want to say thank you to all of our colleagues from Afghanistan and Myanmar who are here today. It's very difficult just being a doctor, having the lives of your patients in your hands, and then to do that while also fearing for your own life requires a level of character and strength that is superhuman. So thank you for all of your work. I have no disclosures. Just a little bit about me. There's a wonderful introduction, but I am by no means a professor. I'm still in training. I'm still learning a lot, and I'm very new to global neurosurgery. But for the young neurosurgeons here, hopefully I can give you a little bit of an idea of the kind of work that we're doing and why it is so important that we do this. And so I want to talk about what is global neurosurgery, the history of it, and then talk about the work that we do in terms of global surgical indicators and the components that encompass systems of care, similar to what Dr. Khan just spoke about regarding neurotrauma. Then how do we take all of that and build capacity in countries? And so what is global neurosurgery? Dr. Andrews wrote a wonderful article in World Neurosurgery a little while ago regarding what do we mean when we say this, and there's a lot of variation. But I like to think that the definition of the clinical and public health practice of neurosurgery with the primary purpose of delivering timely, safe, and affordable neurosurgical care to all who need it is a great definition for this, because it is not simply neurosurgery that is encompassing multiple countries or on a global scale. It does not require neurosurgeons from one country to go and do work in another. Local is global, and it's the work of the local neurosurgeons within their own countries and the public health aspect that is so important to global neurosurgery. So there was the Lancet Commission of Global Surgery back in 2015, and they had some key messages that really drove a lot of this forward. They found that there's 5 billion people that lack access to safe, affordable surgical, obstetric, and anesthesia care around the world. 143 million additional surgical procedures are needed yearly. And then in addition to that, there's 33 million people who, even if they get access to surgery, they spend their entire yearly savings on this and are driven into poverty. And so they then face multitudes of other problems and health issues just by receiving life-saving and necessary surgical care. And so investment in surgical anesthesia care is necessary really for human rights and for basic care for people. Regarding neurosurgery then, these issues become even worse because in certain areas of the world, there's only one neurosurgeon for 10 million people. You simply cannot provide care for that many people. Compared to high-income countries, as Dr. Khan was showing, LMICs carry the burden of a lot of these issues. However, people usually think about neurosurgery as being expensive, and we can't provide neurosurgical care in low and middle income countries. We can't invest in it because it costs too much money. There's other things that we could spend the money on, but really it's relatively inexpensive, $300 US in order to provide surgical care. And that is a lot in some countries, but for high income countries, that is not much at all. And so providing that investment, taking our wealth and helping others in those countries can go a long way. And then there's specific to neurosurgery, 22.6 million patients that suffer from neurological disorders around the world, and 13.8 million of them require surgery every year. When you do the math, this comes out to about 23,300 neurosurgeons who are needed in addition to the ones that we already have back in 2018. And it's a long road to get down, but we need to take it step by step in order to reach that. And so really the history of global neurosurgery, our efforts to improve this are grounded in training. There are multiple organizations. FEAM started back in 1969 has done a lot in developing training programs that are both global, but also local ones in countries to train neurosurgeons to increase the workforce. Cure Neuro with Dr. Benjamin Wharf in Uganda, training neurosurgeons in that country, and then providing a referral center for others to come and train with them in the treatment of pediatric diseases, specifically hydrocephalus and spina bifida. Dr. Khan with the Northwest Hospital has done a lot of work there. Dr. Kato with their foundation, and there's a multitude of others who have done this kind of work around the world. And we see this with the WFNS has also created multiple training programs. They have 21 programs in 13 countries, specifically for LMIC graduates in Southern Africa. You see the COSEXA that has created a training program. Dr. Mohammed Qureshi down there has been instrumental in that work. And so we have a lot of work in training neurosurgeons, but that is only the first step in really providing public health aspects for neurosurgery. And so in 2016, there was this paradigm shift following the Lancet Commission on Global Surgery at the WFNS Congress in Bogota. There's the Bogota Declaration that really pushed public health aspects of neurosurgery to the forefront for the global neurosurgical community. And this is the declaration. Knowing that these numbers that were discussed previously and the tremendous need, especially in low and middle income countries, they wanted to affirm that we are going to do all the efforts in order to achieve this. Everybody, neurosurgeons around the world need to band together. This is not individual efforts here and there, but really it needs to be a global coordinated effort, because neurosurgery is a family around the world, and we're only as strong as our weakest link. You know, we can have augmented reality and AI and robotics in high income countries, but when we cannot even provide basic neurosurgical procedures in some countries, we cannot claim that we are driving the field forward until we lift everybody up. And so that really brings us to how do we address this? And there's the 6 global surgical indicators from the Lancet Commission on Global Surgery, which is access to timely essential care. For general surgical time, it's about 2 hours within a facility. That was based off of obstetric data. For neurosurgery, we found that it's more likely to be about 4 hours to care. SAO density, which is the number of surgeons, specifically neurosurgeons that are needed. And as I said, we need about 23,000 more neurosurgeons globally in order to provide the recommended number of 1 neurosurgeon per 100,000 population. Surgical volume is going to be rooted in that. The number of cases that are needed is going to be based and varied by country to country based off of their disease burden. But you want to have usually approximately about 5,000 cases per 100,000 population is the general number that you're going for. And these are just general indicators. It's not as soon as you reach that number, you're good. It's going to vary country by country, which is why it's so important for data to be collected at a country level for the local neurosurgeons to be involved in these processes to know exactly what their targets should be. Perioperative mortality, the goal is 0%. No patient should die within the perioperative period. around the surgery, which is considered from the data in the Alliance Commission about 1 week around the surgery. And then there's actually 2 indicators for poverty, which just shows how important finance really is. It's risk of catastrophic expenditure. And so that's where the direct out-of-pocket cost of the patient is exceeding 10% of their total income or 40% of their remaining income after they paid for their food and housing and basic necessities, or risk of impoverishment, which is paying for that surgery out of pocket will drive you into poverty, or if you're already in poverty, drive you even lower. And these should also be 0%. Nobody should have to choose between eating and receiving a life-saving neurosurgical treatment. And so that brings us to the components of a surgical system. How do we take these indicators and achieve them? And these were based off of those guidelines for neurotrauma that Dr. Khan was just speaking about. There's 6 components of the health system, which are infrastructure, workforce, service delivery, financing, information management, and governance. Infrastructure is the surgical facilities that you have, the number of CT scanners, MRI scanners, operating rooms. The workforce, of course, is the number of surgeons, but neurosurgery does not exist on its own. We are part of a larger health system, and so you cannot do neurosurgery without an anesthesiologist, without a surgical technician, without nurses, without lab technicians and neuropathologists, and there's so many others that come into that. Service delivery is then when you take those components and how do you provide care to the patient. Financing, of course, is how do you pay for it, which is a big burden, especially in low income countries. And then information management is both the research aspect of how do we collect data, how do we figure out what is the best and standard of care within that country, and how do we then collect data on all the patients and make sure that we are reaching these indicators that we had mentioned before. Lastly, governance. The government has to be involved in this because there are multiple political and policy initiatives that can drive this. And if it was just medical care within the hospital, then you can provide care within a hospital. But as I said, public health aspects of care extend outside of just what's in the hospital. You have, like Dr. Khan was saying, helmet laws that can help reduce the number of patients that even need care, and then rehabilitation afterwards. All of these come from governance measures that protect the population from perhaps even needing to see a neurosurgeon in the first place. And then there are the 5 components, as we were just speaking about, that go into the continuum of care. There's surveillance, is how do you monitor everything that's going on, and this is the information management portion of it. Prevention, if you can prevent somebody from needing neurosurgical care, then that reduces the cost of care overall, but also helps out the patients. And then pre-hospital care is when they actually do need care, how do you get them to the hospital and to the neurosurgeon? And if the neurosurgeon is hundreds and thousands of miles away, then that becomes a very big issue. A lot of countries, they do not even have ambulances, and so people are taken in taxis to the hospital, and in that time, it can worsen because you do not have somebody who's trained in stabilizing them and providing some kind of care that can get them to the hospital. The surgical system is what we all know and practice within. And then lastly, rehabilitation is how does the patient do afterwards? As soon as they're finished with the hospital, we all know they're not done. They're your patient pretty much for life. You follow up with them, you check on them, and there's so much work that needs to be done afterwards for them to recover, especially with traumatic spine and brain injuries. And so the problem has really been that in the past, we have all been doing a lot of efforts going into this, and everybody kind of does their own thing. Everybody works on their own in their own little silos, and really what we need is a concerted effort driven by the local neurosurgeons within these countries to get a well-oiled machine working forward. In a lot of instances, everybody is very well-intentioned, but it has historically been people from high-income countries go into a low-income country, like Dr. Khan was saying, and they say, this is our standard of care in our country. This is how things should be done here, and that's not the case. That's what led to the new development of guidelines for TBI and LMICs, is because what we do in high-income countries does not translate to others. And even within low and middle income countries, every single country, every single context has different cultural, political, religious, and population-based contexts and factors that change how care should be provided and how people approach care and how they attain their care, that changes how they interact with their neurosurgeons. And so this process really has to be driven by local neurosurgeons, why it's so important that global neurosurgery is not something that is from high-income countries to low and middle-income countries. It's something that is driven from the grassroots, from the bottom up, really. And so the WFNS Global Neurosurgery Committee was created with this idea that we really need to coordinate all the efforts that we have going on with all the different organizations and try and get everybody working together as a cohesive team to achieve our goals. And these are the 5 goals that Dr. Khan touched on a little bit: amplifying access to care, advocating for universal coverage, aligning all of the activities that we have so that everybody's working together. Advancing research is extremely important, and it's local research. It's not just research from high-income countries or high-income country actors going to low and middle-income countries and doing research there. We're really providing research capacity building in these countries so that people can study their own people and figure out what's best for them and based off of their priorities and their local contexts. And the last one is assimilating neurosurgical capacity. We do not operate neurosurgeons within a silo. We are part of a larger health system. And global neurosurgery is pretty young compared to global health. There are actors within the WHO, the UN, and other organizations who have been doing this for a lot longer than we have, and they have a lot of expertise. And we should be working with them to connect us with our fellow colleagues in medicine, the same way that a neurosurgeon at a hospital, you cannot provide neurosurgery without working with the primary care doctors. Pediatric neurosurgeons need pediatricians. And so we also need to work with our colleagues as well. And there's some things that we do to help with this. Intersurgeon was an organization created by Dr. William Harkness, the late Dr. William Harkness, who created this platform for surgeons to interact with each other and kind of say, you know, I need this and I'm offering this, and let's connect together and work together to utilize our resources in the best way. And when we all come together, we can start to work towards developing national surgical plans and policy development. And this is really where our work in Afghanistan and Myanmar is based off of. And what I really want to talk about a bit today is neurosurgical capacity building and these improvement initiatives that we have in these countries. And as you can see here on the right, there's the strategic plan development for neurosurgical training in Myanmar. Unfortunately, with our efforts with Myanmar, working with Dr. Shilong, it was stopped after the coup. And so things are on hold there. And as well as in Afghanistan now with American troop withdrawal and the last week of violence with the bombing this morning of little girls at school. There's concern about how much we can do and how much we can help out. But I think these are the instances where it's most important that we stick together and that we help out in whatever way that we can, even if we cannot be there in person. Being there to support our colleagues in these countries and helping them out in whatever way they see is the best way to help out, letting them lead us, and simply providing a helping hand goes a long way. And so these efforts, just to take Afghanistan as an example, is what we do is we bring together colleagues within the country, local neurosurgeons, and ask, what is the issue? Let's collect information on the number of neurosurgeons, where the hospitals are located, what equipment is where, and then what are your priorities? Because we cannot say for a country, oh, this is your problem, this is what you need to do. Rather, it needs to be driven by the local neurosurgeons who understand the situation. And so here we created a map showing where the different hospitals are in the country, and you can see mostly centered around Kabul, the capital in the northeast corner of the country, but there's large swaths of the country that are far from any neurosurgical care. Even some of these centers, they might have a neurosurgeon, but they don't necessarily have a CAT scan or an MRI. And so if a patient comes with a subdural, they might have to be sent to another hospital, get a CAT scan, and then come all the way back. And then by that time, you're 5-6 hours delayed in providing care, and patients die because of this. And so after we figure out what are the issues, what are the basic information that we have, we then work together to determine how do we address this. And so in Afghanistan in particular, we came up with training, communication, equipment, and research as the priorities that they wanted to target. Training is always a big issue, and there's a lot of work done, as I already said. Communication is really coordinating all the centers. There's 3 training centers in Kabul, Jamariat, Aliabad, and Sheikh Zayed hospitals. And there's a Afghanistan Neurosurgical Society, but to improve that collaboration amongst neurosurgeons and bring them all together in the country is really our first step, to have them working together to drive neurosurgery in their country. And so we're actually planning a conference in June for the neurosurgeons in the country to come together, and hopefully we can provide more information once we have that all set and planned for others in the international community to join in and to learn about the situation in Afghanistan and how we can all help. Equipment, there's always a need for equipment, and there's multiple organizations that help provide funding or equipment donations for these countries. And lastly, research. Research is always extremely important because we cannot improve what we do not measure. And so we need to be collecting data in order to know what's our next step moving forward. And so this is always difficult because it requires a lot of funding, and you want to take what little funding you have, what little money, and provide it care for patients. But it's difficult to improve the care for patients without knowing what's the best way to move forward with it. And so there's always a balance, and that's why it's so important for the local neurosurgeons to drive these priorities, because they know best what the situation is and how to provide care for their patients. And so just a little bit about our process. We have a national surgical plan framework going through situational analysis and baseline assessments, getting support from the government, and pretty much figuring out what's the situation. Then we get all the stakeholders together. And so we're at this process of getting all of the neurosurgeons in Afghanistan together as a first step. Then we'll be bringing in all the international partners who want to help out in Afghanistan and getting them in contact and having discussions around that. Then there's drafting, validation, figuring out what are our priorities, how do we do this, how do we monitor this, how do we collect data, what's the cost, and how are we going to fund it? And then the government determining what policies, what laws need to be done, how does the government enact all of this, and lastly, how do we implement this plan and make it a reality? And there's different tools that we are developing for this specifically. There's strategic planning framework. There's about 20 to 30 pages of questions that need to be asked specific to neurosurgery regarding the different components that we just discussed before, infrastructure and workforce and service delivery, that sometimes you just don't even think about the multitude of factors that go into providing care for patients. And then the hospital assessment tool is specific to each hospital. Can that hospital provide neurosurgical care? What equipment do they have? What equipment do they need if they want to start providing, or if they want to improve? And so having that information is extremely important for, once again, figuring out how do we move forward in providing this care. And then the future going forward really is going to be driven by the young neurosurgeons in the world. We need to increase the development of human resources, the number of neurosurgeons, nurses, operating room personnel. Encouraging neurosurgical research is extremely important, specifically local research. Promoting innovations that are practical and cost effective. You know, you can buy a neurosurgical microscope in the United States for $1 million, and it's this very high-tech thing that requires a perfectly flat floor. And if you take that and you take it to a country, a low-income country, it uses so much electricity, it requires so many things that it can break down very quickly and becomes useless, no matter how much it costs. And really, these things need to be designed for low and middle income countries. We cannot simply take what we use in high income countries and say it's good enough for others. There are factors that in those countries that need to be considered in designing these things, and we should be designing things for those countries, not simply donating whatever we have left over. And then we need to advocate for addressing this unmet neurosurgical need. Neurosurgeons are leaders. We are trained not just to be surgeons, we are trained not just to be clinicians, we are trained to be leaders in our field. And so it is our duty to really go beyond just the care of our patient. And in these situations where we see issues like in Myanmar, where there's genocide and murder occurring in Afghanistan, where we're concerned about the care for women and their education. All these issues that affect our patients, we should be advocating for the humanitarian aid needed for it. We should be advocating for everything that encompasses the care of our patient beyond just the operating room. And lastly, precision neurosurgery is a key member of the global surgery community. As leaders, we should really be directing the discussions and helping lead the world's global health community in terms of how do we address this, what are the things that we need to be doing, and showing how we can actually do this through these different methods that we have. And so one thing we mentioned is the Journal of Global Neurosurgery. We had just started this. This is a fully open access journal, free to publish, free to access it. And we're looking for equitable representation from all regions of the world, which means that what we're doing, we're only the custodians of it, really. In order for this journal to work, it requires neurosurgeons from around the world to invest in it by providing research and submitting and helping out. And we're hoping to develop a research building capacity arm of the journal as we start moving forward. We just published our first issue just a couple of weeks ago. And the goal is to help researchers in countries who need help in developing study design and writing up their manuscripts, to assist them with that, so that the way they can submit to not just our journal, but any journal, JNS, World Neurosurgery, any journal that's out there, and to build that research capacity so that we can lift up local research, because it's extremely important for us to understand neurosurgery in all corners of the world. And lastly, multilingual. Down the line, we're hoping to have multiple languages for the journal, because we're all speaking English here today, but that is not the primary language for the majority of people on this Zoom webinar. And we should really be able to support people in their own languages and to push neurosurgical research in all the different languages, and people can read and translate articles from all corners of the world, be able to have access to all of that. So thank you all for any of the young neurosurgeons, students, or trainees who are interested in global neurosurgical work. The WFNS Global Neurosurgery Committee does have a junior committee, a community of like-minded individuals who are looking to learn more, to be involved in all of this. And so please feel free to reach out to me if you want to be involved.
Thank you, Dr. Adam, for a wonderful review about global neurosurgery. Congratulations to you, Key Park, and the whole global neurosurgery team. You are doing an exceptional work. And congratulations for the Journal of Global Neurosurgery, Ignatius Angelus. That is really definitely a good idea, especially for the young neurosurgeons, to provide a free access journal. So congratulations for that. Now we left with only one small presentation from Dr. Shui Yi. She's just going to have a 10 minutes presentation. So we'll allow her to present, and then we'll move on to the last question answer part. Okay, Dr. Sneha, can you introduce her?
Yeah, we're happy to have with us Dr. Win-Shi Yi Po from Yangon, Myanmar. Presently, she is in Japan. She is a resident at the Haegu College of Medicine, and she's done her basic MBBS from Yangon University of Medicine, Mandala. We're happy to have her present in this young neurosurgeon session, Dr. Wenshi. So over to you.
Okay, thank you for
Are
your
you here?
introduction.
Yeah.
Yes. Can I share my screen?
Yes, please.
Yes. Okay, first, I would like to thank to you all for the concerning about the current situation in Myanmar and also encouraging to us. And this is a very, I feel very grateful for the opportunity to be able to join in here. So I would like to talk about the endovascular therapy on the cerebral aneurysms. This is the overview of my presentations and introduction, treatment of the cerebral aneurysm, and endovascular therapy on the cerebral aneurysm, important step in the treatment of aneurysm, strategies, new devices, complications, and take-home message. And before that, I would like to thank Professor Yuko Kato and Professor Miyatu from University of Medicine 1 and Professor Joshua Ang from University of Medicine Mandalay, and for supporting me all the way to be a neurosurgeon. And also, at last not the least, that my great mentors, Professor Shinichi Shimura from Hyogo College of Medicine, for supporting me as always and teaching me to be a neurosurgery, teaching me not only a neurosurgery, but also the moral to be a good neurosurgeon. So actually, I couldn't find any correct word to express my gratitude to this kind of kindness and greatness. So I'm from Myanmar, and I joined in the Hyogo College of Medicine in 2020 in Japan. So this is a little thing about me, and I finished a neurosurgery residency at 2019, and now I am currently the second year graduate student at Hyogo College of Medicine. My ambition is to be a hybrid neurosurgeon. So this is, as all we know, the treatments of the cerebral aneurysm. The first is the open surgery, and second is the endovascular treatment. So I would like to emphasize on the endovascular therapy on the cerebral aneurysm. And I make this slide in the simple way, most simplest form for the beginner like me. So this is a very simple form. The embolization is that there are the simple coin embolization, and there is the adjunctive techniques. It's like double microcatheter techniques and balloon assistant techniques and stent assistant techniques for the wide neck aneurysm. And other is the parent artery occlusions and also the flow diverter treatment. So this is the simple coin embolizations. This is the coilis via the microcatheter without any other devices for the narrow neck aneurysm. So these are the adjunctive techniques. Yes. There are the three techniques, is like double microcatheter techniques, and we use the double microcatheter to embolize the aneurysm. And also the other is the balloon assistant techniques, and to prevent the protrusion of the coil mass, and also the to stabilize the microcatheters, and also the stent assistant techniques. So these are the parent artery occlusion that we use in dolichoastrial aneurysms, like this. So these are the flow diverters for the left paraclinoid gyral aneurysms. So this is a gyral aneurysms, and we perform the flow diverters to the big aneurysms, and we can clearly see the eclipse sign in that. So this is the 1 year after the procedures. We can see the completely disappear of the aneurysm. So these are the important steps in the treatment of the aneurysm. So the vasculatures, the geometry of the versus aneurysm is very important. And the other thing is the strategies. So it's very important to get the good working angles to separate the aneurysm, neck of the aneurysm, and the parent artery and the branches. So we need to identify the clear cut view of the neck of the aneurysm, and also the devices, the available devices, and also the techniques. Techniques is very important, and the different kind of aneurysm, different kind of locations, and we need to use the different kind of techniques. and also the troubleshootings. And we have to think about the troubleshootings. We can encounter any kinds of trouble perioperative periods. So we already have to concern about that kind of things, and also the post-operative complications and about the future plans about the follow-up. So this is the strategies. So we have to choose. It's like a better plans when we perform the procedures. So we have to think about the simple techniques or the adjunctive techniques and what kind of aneurysm, what is the location of the aneurysm. We have to well plan before the procedures. So this is the simple coin embolization, the case 1 acorn aneurysms. We decided to use the simple coin embolization because it is the narrow neck aneurysm. So we perform the coin embolization via the left A1 and we perform the simple coining. So this is the video of the coin embolizations. At first, we perform the framing coins. Filling coins and then finishing coins. This is the finance and geogram. So this is the case to the ultimate artery aneurysm. In this case of aneurysm, the artery is coming out from the door of the aneurysm. So if we cannot do like a original method, like we cannot perform the flow divertance because there is a risk of the embolizations to the ultimate artery. So in this kind of condition, we decided to use the stent assistant coin embolizations. So we use the stent assistant and by the CMG techniques, and then we embolize. Like this, we spur the speed to get the flow to the ultimate artery. So in here, we intentionally left to embolize to get the flow to the ultimate artery. So there is another case, it's the wide neck basalactic aneurysm. So in this kind of case that we use the stent assistant coin embolization, we try to use the double wide stent techniques. So like this. So after that, we can embolize and then deploy the stent. So these are the new devices. There are the different varieties of the new devices, but these 3 devices are now currently available on the Hyogo College of Medicine. So the flow diverter, FRED, and pass rider, and then WAP. This is the flow diverter, FRED. So this is the pass riders. So we use the pass rider device and the basalactic aneurysm. There's 2 types, T-shape and Y-shape. This is the pass rider device. So this is the WAP. WAP is the intracircular cage. So we can clearly see here. We can use its WAP device in the basalactic aneurysm or carotid terminus like this, but we cannot use in the like bilobe aneurysm or irregular-shaped aneurysm. The advantages of the WAP is that we can reduce the time or the antiplatelet therapy regimes. So this is we use WAP in the basalactic aneurysm. So let's like this. So these are the complications. And so the important thing is that we have to care about that intra-procedural aneurysm rupture of intra-procedural thromboembolism or parent artery dissections, or parent artery rupture or perforation, or sometimes we can face the coin troubles, and also the puncture site problem and post-procedural thromboembolism. So there's a take-home message. So we have to know the importance of the vasculature is very important before we perform the procedures. And we have to master in the available of the device, and we have to know the available of the method, and the strategy is the very important. And also the troubleshooting, and also the pre-procedural complications. We have to solve this kinds of problem, and also the follow-up. This is one announcement that now currently we are working on the ebook applications. The ebook for the beginner guide for the neuroendovascular therapy will be available soon in Amazon, US or the Japan, with only $1 because we intended to distribute to all the beginners. So it will be available soon. We are currently working on this. So thank you for your precious time. Thank you.
Thank you. Thank you very much, Dr. Sui. Congratulations for the excellent work you are doing. All the best for your next future, and all the best for the ebook. That is really nice concept to have a new ebook for the endovascular neurosurgery. Thank you very much. Now the floor is open for the discussion. If you have any questions, please put forward. Dr. Liu?
Sachin, there's a question which has been posted by Dr. Ditto Darlin.
Yep.
And this is open to the floor. He's asking about the current situation, and in this pandemic, how did your institution do to improve the quality of the training program? You know, he's basically a resident from Indonesia. Okay. Is there any different challenge before the pandemic happened? And he wants to know anything different was done anywhere.
I think this question is to Professor Tariq Khan and Dr. Adam Amar. That as long as the neurosurgery, the neurotrauma is concerned, is there any difference pre-pandemic and post-pandemic in the recommendations for the management of neurotrauma?
Well, you know, first of all, in the initial periods of the pandemic, because of the lockdown period, most of the patients were stuck at the local level, and they were unable to be transported into the main neurosurgical centers. And I think there was a lot of online consultation which was being carried out between the neurosurgical departments and the local level people on how to manage. And I think this is where it comes on the issue of which I touched a little on how to train surgeons to be able to do basic neurosurgery, like basic craniotomy for hematomas, etc. like that. There are many areas where there were CT scans available, but there was no neurosurgeon available. So that was one aspect of it. The second was that the training of the young neurosurgeons was affected because the numbers of cases coming in, at least into our departments, were less, again, because of the lockdowns. But a lot of gaps were filled in by online webinars done by a lot of organizations like yourselves, like by WNS, like by the Pakistan Society of Neurosurgeons. So those gaps were filled. I know it's a fact that online cannot be a replacement for hands-on trainings, but it certainly did help and fill in the gap. And the very important thing was, good thing which came out of this pandemic, if I may say so, is that many young neurosurgeons who could not go and attend meetings in different countries, now because of these webinars, those meetings have come to their houses and they're able to benefit from a lot of talks like just now about the aneurysm surgeries, etc., at home. Thank you.
Sir, good evening, sir. My question is, sir, are we in the lower middle income countries, are we doing more than required number of decompressive techniques right from our residencies, which may not be even be required just in the name of primary that we don't have resources, because after passing out there's a drastic change, like we might do a decompressive for ICH also in our residencies, but it's not required, I think, decompressive and ICH later in our when we go out and work. So is it our over reliance on primary decompressive? Are we going astray?
Yeah, thank you. Very nice point. I must say something. When I was young and when I was training back in Ireland and UK, back in the early 80s, one of my consultants would say that it takes 10 years for a neurosurgeon to decide when to operate, and then it takes another 10 years for the neurosurgeon to decide when not to operate. So, you know, as age goes by, you become more conservative towards maybe if not required, don't do that. Regarding decompressive craniectomy, it's a very difficult question. The pendulum has been swinging back and forth. Sometimes, you know, everybody's educating for a lot of decompressive craniectomies, some are not. A new concept is coming up about hinge craniotomies, where you can do a decompression and then put the bone flap loosely on the brain as well. Patients who cannot afford multiple CT scans, they are doing decompressive craniectomies as even a prophylaxis. You may say that maybe we are doing too many, but the countries where they don't have intensive care, the countries where they cannot ventilate the patients, I think they may be justified in some fashion in doing erring on doing more than less decompressive cranectomies.
Another thing, that will the requirement of 4 score, like it's a new score apart from GCS, will it be involved in the care, the 4 scores? And there's a second thing known as cystinostomy, which has been widely propagated now. So will that microsurgical cystinostomy be involved in a regular trauma care anytime soon?
Yeah, first I'll talk about cystinostomy. You know, a very burning debate all the time on this. There is no harm in trying as many techniques as possible to ensure a better result for the patient's outcome, definitely. But we must understand that, first of all, cystinostomy, you must be very well trained in microsurgery. You have to first be very well certified in microsurgery. As a young neurosurgeon, you should not be trying to do cystinostomy, number one. Number two, where there's been a lot of debate and controversy on discussing that, is the importance of evidence-based guidelines. I know we might say in the lower middle income countries that it's very difficult for us to gather evidence, but really that's not an excuse. We need to look at the evidence. We need to try and hope that we have something which is good. Why not? But microsurgery experience is very, very valid to do that.
Thank you.
I must add something here regarding which Adam said. I think global is the key word. Global neurosurgery, globalization of neurosurgery, that everybody must be able to help everybody. And as the time was, that as I said, that these were the gold standards of guidelines for neurotrauma care. We must look beyond those gold standards of neurotrauma care, the Brain Trauma Foundation guidelines. We have to strive towards that, but that should not keep us away from developing resource restricted guidelines. Whatever resources we have, we should be able to develop guidelines according to those resources. I think that is something very, very important. I think the Global Neurosurgery Committee is doing an excellent job also trying to develop capacity throughout the lower and middle income countries. I must congratulate Key Park and all the people in that.
And if I could just say, the resource Stratify, I think applies even in high income countries. In New York, where I'm at, there are plenty of times where we've done prophylactic decompressive hemicraniectomies. You know, there's times when our ICU is overrun and our patients are sitting in the emergency room or elsewhere, and they cannot get the same monitoring that is required for us to do the other tier steps. And so it's not simply something that occurs in low and middle income countries. There are different resources, even within high income countries in the US. There's portions of the country where, you know, patients do not have access to neurosurgeons either. And so we have to be cognizant of all the factors within our countries, and everything's different based off of the population and where you're at.
So how much will be the force score, this new force score which has come up, being relevant in the clinical practice? Is it surpassing GCS or is it still under evaluation?
Yeah, I think it's not yet really, you know, I'm not too very familiar with this score either. So I can't comment on that.
Thank you.
Dr. Adam? Yeah, go ahead, no problem.
Yeah, I was just going to ask any further questions. Sachin, do you have a question for Dr. Adam?
No, I just wanted, Dr. Adam, can you tell us more about this Journal of Global Neurosurgery? What is it about? And I think it's really nice idea to have an open platform for young neurosurgeons. Can you just brief what is this about and who's, like, how's it running?
Of course. So it was based off of two broad ideas. One is within academic literature recently, there's been a lot of discussion regarding the financial structures that exist. You have these large publication bodies such as Elsevier with these journals that charge very large access or publication fees. And what that does is either people in a lot of countries cannot read the articles because it's too expensive to subscribe to it, or they cannot publish their research in it because it costs, some of them cost upwards of $5,000 US, which is even expensive within the US to publish. And because, you know, the editors are working for free, us as surgeons, we're doing the research, we're publishing it, we're doing the editorials and the reviews, all of this, we're not being paid for. Where does the money go is the question. And there are aspects of, you know, advertising and maintaining a website and all of that that goes into it. But as things move more and more electronic and being on the web, you don't have to do publishing hard copies of journals, the costs go down. But it's still restrictive for the large majority of neurosurgeons around the world. That plus the ability to provide research in these journals is difficult because, one, there's language barriers. There's a lot of good research that comes out of, you know, the non-English speaking world, but because translating it becomes difficult or very expensive in some cases, you cannot publish in the high-end neurosurgical journals, or simply there isn't a focus on providing a platform for a lot of these publications, or a lot of this research to be distributed to the rest of the neurosurgical community. There's local journals that are published in, but then they're not indexed on sites. And so we do not have access to research from around the world. And so taking those two together, we wanted to create a platform that's completely free for people to publish in and for free to access, and then to provide an ability for local researchers who want assistance in learning how to do a study design, how to write a manuscript, and translating their articles, then to be able to publish and find a platform that will be hopefully indexed on PubMed and larger international platforms for everybody to have access to, or to create the ability to publish within the larger and well-known journals such as JNS, World Neurosurgery, and really to get research from around the world to be available for everybody, because right now everything that's out there, these guidelines that Dr. Khan's talking about, come from high-income countries, and that's not really useful in the large context of neurosurgery. And so we really need to have ability to get data from everywhere and make it available to everyone.
Thank you. Thank you. That's an excellent work you are doing. The whole group, the whole committee, you, Key Park, Ignatius, and Angelos, congratulations to you all. Thank you very much. Yes, Dr. Sri, you want to say something?
Yes. I would like to request one thing is like, according to current condition in Myanmar, we cannot do anything. Like some young people, young trainee, or young neurosurgeons, and people are now, they are running because the gender want to arrest them. So the current condition is very difficult, but I hope it will overcome one day. And I think my country, our country need help, like the research is weak in my country, like a clinical research. So I hope after we overcome these conditions, and we need a lot, we might need a lot of help from the global group or global society. Like I would like to develop the clinical research program in my countries. So I hope after we overcome these conditions, we need to develop the research things.
Yes. I think ACNS is totally committed to provide you whatever platform you need for development of research, as long as the research is concerned in Myanmar. So any help all the participants from Myanmar, Afghanistan, any help you need, please write to us through our support group, which we have created. We will try to help you whatever way possible.
Thank you. I hope so. So thank you.
Thank you. So, is there any question?
So Russell, Dr. Russell, maybe you can say something for the doctor from the WINT, from the Myanmar.
Well, I just want to emphasize that we all need to take this personally and do what we can with our local countries that we're in, with their governments and their relationship with the United Nations and the World Health Organization, and just keep up the awareness of what's going on in Myanmar. I think one of the sad things is it's gone on for 3 months, and there's this kind of like pandemic fatigue, that these issues can be, they become the new normal if you just let it become part of your daily routine. Say, well, another 100 people get murdered today in Myanmar. You can't let that happen. You have to just take it seriously and decide that you're going to do something each day to try to improve the situation, whether it's in Afghanistan or Myanmar. Myanmar, I think, is probably the most crucial. And we talk about investing in neurosurgery in developing countries. You've got to pick your battles. There are places where you could put in a lot of energy, and because the reason it looks stable is there's one individual who happens to retire or die, and then your facility falls apart. And there's other places where the infrastructure is secure, and an investment will have a great return as far as improving a lot of the care for the people in that area. I think Myanmar, the civilian government, it's clear that it's unlike Syria, for example. If the military junta was out of power, they would proceed very, very productively. And so that's a battle that's really worth fighting. Again, when we look around the world, there's all sorts of places we could put our energies into improving neurosurgical care. But I think that's one where, as soon as this situation is resolved, you'll see a dramatic progress in neurosurgery, just because of what's happened over the last decade when there was this, quote, disciplined democracy. So again, I think the big thing is don't let it go on the back burner and choose your battles wisely so you don't get burned out spending a lot of time in areas where it may feel good initially, but the long-term benefit is minimal. Other thoughts from other people?
Thank you for encouraging us. We believe we will win in this battle.
Yeah, they're very dedicated. It's very heartening to watch that.
Good.
The
Nice to
justice
see
shall
your positive
prevail.
spirit. Yes, you want to say something, Dr. Win?
No, that's
Okay.
okay. Yeah, that.
Yeah.
Yeah, we will go on until the end, and we hope we will have the brighter day coming ahead of us. To see you all and have our training as much as we can. And the days we are hoping and we are looking forward, and we believe that the justice shall prevail, and at the end, and the junta, the military, shall end. Thank you all for your support and love and kind. Thank you all.
Thank you. Thank you. Keep up that positive spirit. At the end, this positivity and the togetherness will definitely win. Thank you. Thank you very much. If there are no questions, can we have a last word from Professor Kato, and then we'll wind up.
Well, thank you very much for all speakers. So it's very worthwhile to listen to your very experienced report. So as ACNS already, the Dr. Sajin, he mentioned we can do as much as possible for your country, both countries, I think. So and also I thank you very much, especially Dr. Tariq Khan and also the Dr. Adam. Both of them is the focus on the especially the Afghanistan situation improvement, I think, and also Dr. Russell. So please continue your spirit to improvement of the Myanmar situation. Thank you very much for all your attendance today. Thank you so much.
Thank you very much. Professor Azmi, you want to say something?
Okay, on behalf of the ACNS YNS group, so we will stand behind you. So we are as a family in Asia, so we will provide any support, especially in education, publication, whichever way that we can within our capacity. So you have this YNS platform, you can communicate with us through Sachin or any other ways. And we hope everything will get back to normal soon and stay strong. And we always behind you to support. Yeah.
Thank you. Thank you very much. Thank you, everybody, all the speakers, Professor Russell Andrews, Professor Tariq Khan, Dr. Adam Ahmad, and Dr. Win Shui. It was an excellent day, evening or morning today. And we had a wonderful participant. We had total 250 registration, and all the time we had around 100 participants. Even now we have around 93 participants. It was an excellent discussion today, and very nice interaction from all the participants. We had this session going on YouTube live, but I think we'll take an opinion from Dr. Russell Andrews and Professor Kato that we'll keep that YouTube video live or we'll take it out, considering that we have discussed certain sensitive issues. So with that thing, I think we can wind up. Thank you very much and have a nice day.
Thank you. Thank you very much.
Thank you. Tariq, thank you very much.
Thank you.
Stay safe, everybody.